I work in Citizen Specialty Hospital, and today I'm going to be talking about acute exacerbation of asthma and COPD. Asthma and COPD are both chronic inflammatory diseases. There's a trigger factor which causes the airway inflammation. This leads to increased secretion of mucus, constriction of the airway muscles, swelling of the membranes. This leads to narrowing of the breathing passages and the patient's presence with cough, wheezing, shortness of breath, and tightness in the chest. However, there are certain differences. In COPD, both the airways and parenchyma is affected, whereas in asthma, only the airway is affected. Airflow limitation is fully reversible in asthma, whereas in COPD, it is not. An exacerbation is defined as an acute worsening of respiratory symptoms that results in additional therapy. Symptoms include cough, wheezing, breathlessness, chest tightness, sputum purulence, and volume. Exacerbations are mainly triggered by respiratory viral infections, although bacterial infections, environmental factors such as pollution, tobacco smoke, wood smoke from stove, and ambient temperature may also initiate or amplify these events. Inhaled allergens such as dust mites, animal dander, mold, mice, and cockroaches are of particular importance in triggering asthma. Initial assessment. In initial assessment, first we should clinically examine the patient. Look for features of severe attack. Severe breathlessness, when the patient is too breathless to complete sentences in one breath. Tachypnea, tachycardia, silent chest, cyanosis, accessory muscle use, altered consciousness or collapse indicate a severe attack. Pulse oximetry should be connected and oxygen saturation should be noted. Blood gases should be done to look for hypercapnia. X-ray should be done to look for pleural effusion, consolidation, pneumomediastinum, and pneumothorax. Management. Management essentially comprises of pharmacological management and supporting the oxygenation and ventilation. Inhale bronchodilators. Bronchodilators, they act on the airway muscles and cause them to relax. This helps with the wheezing. Two groups of drugs are essentially used, beta-2 agonist and anticholinergics. Beta-2 agonist examples are salbutamol, levosalbutamol, and terbutaline. Anticholinergic example is ipratropium bromide. These inhaled bronchodilators can be administered either using a metered dose inhaler with a spacer or nebulizers. Anti-inflammatory, that is systemic corticosteroids, can be given either orally or parenterally. For example, prednisolone and hydrocortisone. For administration, both metered dose inhalers and nebulizers are equally good. There are certain advantages and disadvantages of each. For example, metered dose inhalers, they need to be given under supervision and we need to make sure that the inhalation technique and coordination is there. Whereas in nebulizer, inhalation technique and coordination is not required. They are easy to use. However, there is a lot of wastage, lot of gas gets released to the atmosphere, a lot of medication is left behind in the reservoir cup. The nebulizer. Nebulizer is basically a device which converts the liquid solution or the suspension into the aerosol, which can be inhaled by the patient. Different types of nebulizers are there. Jet nebulizer, ultrasonic, vibrating mesh plate. What we are using commonly is the jet nebulizer. This is the jet nebulizer. If we see inside the jet nebulizer, there is a compressed gas source, which can be either a compressed air or oxygen, which comes in through the narrow tubing. This creates a low pressure, and this picks up the drug, the salbutamol, which we are putting in the reservoir, and the drug is then broken into small droplets, and these droplets go and hit the baffle, and this breaks them into even smaller droplets. So by this way, a aerosol is created, and this aerosol comes out from here and is inhaled by the patient. Nebulizers can be oxygen driven. So the nebulizer can be directly connected to the hospital pipeline system or the pressurized cylinder. No special device is required, or they can be air driven. This is a portable device which causes air compression. It is important to connect it properly when we are using the nebulizer in the ventilator along with the ventilator. This is the T connector which is used to connect the nebulizer in the circuit. Always remember to connect the nebulizer close to the patient next to the xylem of the circuit. If we connect it away from the patient, most of the drug is going to get deposited in the circuit and get wasted. Also, when we are using a HME, always remember the HME will block the nebulized medication from reaching the patient. So the HME filter should never be in between the nebulizer and the patient. Another point, when we are using a T-piece, and there is a special kind of T-piece which is valved or spring loaded, the advantage of using such a T-piece is we need not disconnect the ventilator circuit again and again, causing loss of pressure. Instead, we can just disconnect the nebulizer device from the T-piece and close the gap. Other agents which are used are magnesium sulfate. IV magnesium sulfate is used in refractory exacerbation of bronchial asthma. Anesthetic agents such as ketamine and inhalation agents such as halothane, they also cause bronchodilation. They are only used in refractory status asthmaticus. Nebulized adrenaline has not shown any benefit over nebulized salbutamol or terbutamol, hence we don't use it. IM, subcutaneous or IV adrenaline should only be reserved for those patients in which inhaled therapy cannot be used reliably. Heliox, or the name for helium oxygen mixture. Low density of helium, it reduces airflow resistance. It is used as a driving gas for nebulizer, as a breathing gas, or for artificial ventilation in adults of acute asthma, which is not responding. Methyl xanthines or IV aminophylline. It is only used in cases of near fatal asthma or life threatening asthma with poor response to standard therapy. They have a lot of side effects such as arrhythmias and vomiting. While we are treating the patient with bronchodilators and anti-inflammatory agents, it is very important to keep on supporting the oxygenation and ventilation. Oxygen should be given to all hypoxemic patients. The target should be different. In asthma, we target a saturation of 94 to 98%, whereas in COPD, we target about 88 to 92% saturation. In COPD cases, we should be very careful not to over-oxygenate the patient. Supplementary oxygen can be given through various devices and delivery systems. Oxygen delivery systems are broadly divided into low flow and high flow systems. Low flow systems provide oxygen where the flow is actually lesser than the inspiratory flow of the patient. So when the patient inspires, the oxygen is diluted with the room air, and the degree of dilution will depend upon the inspiratory flow generated by the patient. Hence, these do not allow for accurate calculation of the inspiratory oxygen fraction. High flow system provide flows higher than the patient's inspiratory flow. Hence, the FiO2 is stable and is not affected by the patient's type of breathing. Examples of low flow devices are nasal bronchs, simple face mask, non-rebreather mask. Example of high flow devices are Venturi mask, high flow nasal cannula, non-invasive ventilation, and invasive ventilation. Nasal cannula. Nasal cannula is used for mild hypoxia. It can provide FiO2 from 24% to 40% with flows ranging from 1 to 6 liters per minute. Keep in mind that increasing the flow rates beyond the maximum, that is, if I increase more than 6 liters per minute, I will not achieve a FiO2 more than 40% of FiO2. So if patient is hypoxic with the 6 liters per minute, it is time to change your oxygen device. Do not keep on increasing the flows. Advantages of nasal cannula. Patient can talk and eat while receiving oxygen. They are easy to use, cheap and disposable. Limitations, they are easily dislodged. They are not as effective if the patient is a mouth breather or has blocked nostrils. Similarly, if we are using high flows for over a long period of time, it causes drying of nasal mucosa, nasal irritation, crusting, and epistaxis. Simple face mask. Simple face mask is used for moderate hypoxia. It provides from 40 to 60% of FiO2 with flows at 5 to 10 liters per minute. Again, a reminder, do not keep on increasing the flow. Increasing beyond 10 liters per minute will not increase FiO2. At the same time, when we are using a face mask, do not use oxygen flows less than 5 liters per minute because it will lead to rebreathing of the exhaled gases. This will lead to increase in carbon dioxide level. Disadvantages: it is difficult to eat with the mask on, and some patients may feel claustrophobic with the mask. A non-rebreather mask. A non-rebreather mask has a reservoir bag to deliver a higher concentration of oxygen. It can provide 80 to 95% of oxygen with flows at 10 to 15 liters per minute. It has a one-way valve on the side of the mask which allows the exhaled air to escape freely and prevents entrainment of room air. There is also a one-way valve between the bag and the mask which prevents the exhaled air of the mask to return into the reservoir bag. When we are using NRBM mask, always be careful because we are giving high FiO2. There is a risk of carbon dioxide levels to go up. Venturi mask. Venturi mask is a high flow oxygen device. It can deliver from 24 to 60% oxygen. It is color coded. The correct flow rate to use with each color is shown on the mask along with the percentage of the oxygen delivered. They are often used in COPD where it is important not to over-oxygenate the patient. High-flow nasal oxygen therapy. High-flow nasal oxygen therapy delivers high FiO2 heated and humidified gas, which is better tolerated than NIV. The basic components are the air oxygen blender, which can achieve FiO2 ranging from 21% to 100%, irrespective of the set flow rate. The heated humidifier, which saturates the gas mixture at temperature ranging from 31 to 37 degrees, and the heated tubings, which minimize the condensation from the heated humidified gas. Non-invasive ventilation. Non-invasive ventilation is delivered with a tight-fitting mask which is attached to a ventilator. The ventilator may be an ICU ventilator or it may be a portable ventilator. Indications of using NIV is respiratory acidosis where carbon dioxide levels are more than 45 with a pH less than 7.35, persistent hypoxemia despite supplemental oxygen therapy, and clinical signs of respiratory muscle fatigue or increased work of breathing. There's two types of NIV, continuous positive airway ventilation and bilevel positive airway pressure ventilation. In CPAP, the ventilator delivers the same pressure throughout the respiratory cycle. So same pressure during both inspiration and expiration. This helps to keep the airways open and reduces the alveolar collapse. In BiPAP, on the other hand, the ventilator delivers two different airway pressures. The expiratory pressure is analogous to the PEEP. It helps to keep the airways open and reduces the alveolar collapse. The inspiratory pressure is a higher pressure which aims to augment the patient's inspiratory effort. NIV masks are different types: nasal mask, oronasal, full face, and helmet. These are used according to the patient comfort levels and according to the indication. In oronasal mask, there is vented mask and non-vented mask. In vented mask, here we see there are perforations. This allows the exhaled carbon dioxide to come out. In vented mask, since the CO2 is already coming out from here, we can use it with single limb breathing system. The single limb breathing system is often used with portable NIV machines. Non-vented mask, since there is no perforations for the CO2 to come out, it needs to be connected to a separate exhalation port for the CO2 to come out. This is when we are using a single limb breathing system. If we are using, otherwise we can use it with a dual limb breathing system where there is a separate limb for the exhaled gases to come out. invasive mechanical ventilation. Indications are NIV failure, unable to tolerate NIV, diminished consciousness, persistent inability to remove respiratory secretions, severe hemodynamic instability, severe ventricular or supraventricular arrhythmias. To summarize, early recognition and intervention are critical for successful management of asthma and COPD exacerbations. The basic principles of care are assessment of attack severity, use of inhaled bronchodilators, systemic corticosteroids, and maintaining adequate oxygenation and ventilation. Thank you.